you said, my name's Matt Brady. I am a colon and rectal surgeon and medical director of the colon and rectal surgery program here at Mission Hospital. Thank you all for joining us today for this webinar. Today we're going to talk about hemorrhoids, but as well as some other diagnoses that are often mistaken for hemorrhoids or lumped in with hemorrhoids. I don't have any disclosures. This is me. I've been here at Mission Hospital for coming up on 3 years now, and have been serving as the medical director of the colon and rectal surgery program. And I figured for the first part of the talk, I should just say what colon and rectal surgeons do. Usually when I meet people, either friends or family, and definitely patients in clinic, one of the first questions I get is, why would you pick a career like this, or what would make you want to do this? But it's an absolutely great field to be in. We take care of a wide array of problems. We take care of colon cancer, rectal cancer, anal cancer, various small intestinal cancers. We take care of patients with chronic diseases like Crohn's and ulcerative colitis, and then benign problems like rectal prolapse and all the anorectal conditions such as hemorrhoids, anal fissures, anal abscesses, fistulas, cases related to anal human papillomavirus such as warts or pre-malignant conditions for anal cancer and pilonidal disease. And these diagnoses have really a wide array of what we do to treat them. There's very big surgeries that take all day to perform, a lot of laparoscopic and robotic surgery. And then with the anorectal conditions, much smaller surgeries that can take, something as short as 5 minutes sometimes. And what's most rewarding is these are oftentimes somewhat embarrassing problems. People do not like to talk about these problems with their own friends, sometimes even their physicians. They live with these diagnoses for a long time, and you can really provide people with a lot of relief and bring a lot of ease to their life, and just explaining what they have, what's wrong with their bottom. And sometimes it doesn't even need any treatment at all. It's just all within the realm of normal. My own background, I'm a transplant out here to California. I grew up in the Northeast, and with it all the swings from the very pretty springs to absolutely abysmal winters. These are two of the same photos from where I did my undergraduate training in Worcester, Massachusetts. The one on the right where they were buried in 100 inches of snow that winter. So sometimes very bleak. But I never thought I would leave the Northeast. I did my medical training in Boston at Tufts University for medical school, and my residency training for surgery at Boston University, and our teaching affiliate was Boston Medical Center. So about 2 subway stops away from each other, maybe less than half a mile. But I spent most of the 2000s between those 2 institutions. And what brought me out to California was my colon and rectal surgery training, which is an extra year of fellowship training after residency, which I did at UC Irvine. I stayed on staff there for a few years, and then the opportunity arose to come down and join a group down here at Mission Hospital, which I jumped at that opportunity. And this is Mission Hospital in Mission Viejo on the left, which I'm sure a lot of you are familiar with. It's an absolutely wonderful place to work. It's an excellent place to be taken care of as a patient. I always tell people we had my father-in-law come from out of state to have a surgery here, just because everything just top to bottom, between the operating room, the nursing care before surgery, after surgery, and all the facilities, patients are just really well taken care of. This is probably the favorite hospital I've ever worked at. On the right, you can see the Leonard Cancer Institute, which has been here since I've started, but relatively new for the community, and then a shot from the inside. And this is really a unique place. Our surgery group is housed here on the 4th floor, and a lot of our colleagues are here as well. The medical oncologists who also take care of our colon and rectal cancer patients are right across the hall from us. The gastroenterologists who do a lot of the workup and diagnosis and colonoscopies are right downstairs on the 3rd floor. and all the diagnostic imaging is on the second floor. It's a really beautiful place. If you haven't been, it's a really nice place, and it'd be worthwhile to check out. This is the surgery group I'm a part of, feel lucky to be a part of. There's 5 of us in the group. In this photo, we're missing just one of us, but from the left, there's Dr. Ahmad Abu Abbas, Louise Bacon, John Shaver, myself, and our phenomenal breast surgeon, Marla Anderson. And I feel very lucky to be a part of this group. We are housed in the Cancer Center at Mission Hospital and probably do the majority of our surgeries here at Mission Hospital, and really are able to take care of anything and everything that comes through the door. So on to the kind of more meat of the talk. There are a lot of patients that come in with problems with their rectum and anus. A lot of times pain or bleeding. Those are probably the 2 of the most common complaints. And there's a lot of reasons patients can get these complaints. There can be issues with their hemorrhoids. Patients can have diagnoses like anal fissures, or they can be experiencing an infection like an anorectal abscess. I think one big thing to say about them is that these are common problems. Millions of people experience this every year. Like dating back, there was a report in 2004 that I think hemorrhoids alone had 3 million ambulatory visits. So people going to see their physician or urgent care for issues related to a hemorrhoid diagnosis. You know, it's an incredibly common problem. You don't hear much about it. People will just love to tell you they tore their ACL, or they got, you know, a knee replaced, or they got, you know, their shoulder operated on, but it's not that frequent that you hear your friend had hemorrhoid problems. But you definitely, if you don't think you've met someone who's had issues with their hemorrhoids or an anal fissure in the past, you just did not hear about it. You definitely know someone who's experienced this or experienced this yourself. These diagnoses have a lot of embarrassment associated with them. People just don't like to talk about anything related to their anus. There's a lot of fear associated with it. Anytime you see bleeding with a bowel movement, that can be caused by colon or rectal cancer, and that kind of can have people, you know, quite alarmed seeing blood in their bowel movement until they get a firm diagnosis of what it is. So there's just a lot of anxiety that surrounds these diagnoses. And probably most of all, it's a challenging area for patients to do self-diagnosis. It's difficult to see. It's difficult to ask a partner or family member to look for you. So there's a lot of kind of question marks in people's mind when they come in with these issues. For the anal anatomy, I think it's important to know hemorrhoids are a normal part of our body. Everyone's born with hemorrhoids. You have 2 arms, 2 legs, and 3 hemorrhoids in the vast majority of people. There's 2 on the right side of the anus and 1 on the left side. And they're just a venous plexus that starts up inside the distal rectum, extends through the anal canal and out onto the perianal skin. And throughout life, those hemorrhoid veins can swell, and it's when they swell and get chronically stretched out that they become a problem. They typically will swell for various reasons, usually something related to straining or increased venous pressure. So women will experience them in pregnancy from their uterus, or maybe sitting on some of the big pelvic veins. They'll experience it from delivery and pushing. People can experience hemorrhoid swelling and dilation from straining with bowel movements with chronic constipation. They can experience it from issues with chronic diarrhea as well. Anything that increases your time on the toilet will increase swelling in the hemorrhoid veins, because when you sit on a toilet, really all the pressure of your body is kind of focused right down to the center of the toilet bowl where your anus is. Probably with the advent of smartphones, sometimes people spend more time than needed in the bathroom, and that can lead to hemorrhoid problems. Really, just anything that winds you up on the toilet for longer than a few minutes can lead to these hemorrhoid veins swelling. Heavy lifting, some people with certain jobs that exert a lot of physical activity, and people who are in activities like weightlifting and certain sports can have hemorrhoid exacerbations as well. We break hemorrhoids into, let me go back 1 slide, 2 real types, internal and external hemorrhoids. And those are based on their relationship to what's called the dentate line, which is a division in the anal canal that separates the rectal mucosa from the perianal skin. The same way it changes on the way in, how it goes from the skin on our face to more of a soft, slippery coating inside your mouth as it transitions into the digestive tract. That same transition has to happen on the way out, and it happens at the dentate line. So internal hemorrhoids, which we'll talk about in a sec, are above the dentate line, and external hemorrhoids are below the dentate line. Internal hemorrhoids are covered by rectal mucosa, and external hemorrhoids are covered by skin. For kind of an easier way to think about it, external hemorrhoids you can see from the outside just by kind of spreading your buttocks, and internal hemorrhoids require us to look inside the anal canal with a small retractor. External hemorrhoids probably get the most press, probably get the most marketing with regards to pharmaceuticals and remedies and different treatments. When people talk about having had hemorrhoids in the past, a lot of times this is what they're referring to. External hemorrhoids will present as sort of a painful lump next to the anus, and what it is the pressure in those veins will rise, and sometimes the vein can either rupture or the blood inside it will clot off as the skin can't stretch anymore and pressure gets too high, and you get a big blood clot in the hemorrhoid complex. It's not the type of blood clot you need to worry about causing a pulmonary embolism. Sometimes people have asked me that. It doesn't, travel to the lungs or travel anywhere. It just sits right in the hemorrhoid, similar to if you were to get a blood blister if you accidentally hit your thumb with a hammer or had a really severe bruise. Throbbing pain, and it starts very acutely. People can usually pinpoint, the day and even the time that it started. They don't typically have bleeding. Occasionally they can have bleeding if it gets really swollen and the skin ulcerates and that blood clot leaks out, and it'll look kind of like a dark maroon color, not a bright red blood. Very often these are brought about by an acute episode of straining, such as lifting something heavy, helping someone move, doing some physical activity that maybe you haven't done in a while and you really exerted yourself, or potentially a very firm bowel movement that required straining to pass. When people experience constipation, especially with travel, that's a common time we'll see an external hemorrhoid thrombosis. How do we treat these? When they're mild, a lot of times we'll just go for symptom relief. Patients will use Tylenol or non-steroidal anti-inflammatories like ibuprofen. We'll start them on a fiber supplement like Metamucil or stool softeners, increase their water intake. Those two are designed to soften people's bowel movements, to make them so they don't have to strain at all. You really want your bowel movements to be a very soft consistency that's very easy to pass, and you can decrease your toileting times that way as well. When people have more severe symptoms, that's when we'll talk about excising the hemorrhoid. Typically, if patients come in, you see this little graph here, in between 1 and 4 days of the episode happening. So let's say they had their hemorrhoid thrombosis on a Monday. Typically, if they come in that week, they'll benefit from having it excised, meaning the pain of the procedure will be less than just leaving the hemorrhoid alone. But with time, those blood clots will just go away and the pain will resolve all on its own. So typically if someone gets, over or, a week out, you can see here at the 4-day mark, they say to put them on observation. And that's because the pain of the procedure will be worse than just waiting another day or two, and then the pain's going to go away all by itself. The blood clot takes longer to go away. That can take weeks to go away. Sometimes I'll see people and they say they had this painful episode 3 weeks beforehand and they feel better, but they still have this persistent lump they're very worried about. And that just requires some reassurance, because with time, it's just going to go away. The same way a bruise takes weeks to go away, it goes through that purple to green to yellow transition, and then goes away completely. The same thing happens with these hemorrhoid clots. When people do come in those first few days, this picture on the left is typically how we'll manage it, where we'll put some numbing medicine like lidocaine or novocaine, just like at the dentist, right on the skin around the hemorrhoid. And then you make a small incision over the hemorrhoid and remove the hemorrhoidal clot. This is what we do in an acute setting. So someone's coming in pain and they need sort of more immediate relief. On the right is a different setting. This is more of an elective setting where someone's had repeated hemorrhoidal thrombosis. They've had that hemorrhoid clot off multiple times in their life, and they want it removed completely and to not happen again. So in that setting, what we'll do is in the operating room with the patient under anesthesia, we'll excise the entire hemorrhoid complex, the whole complex of veins, and then sew that defect shut again. The difference between these two, the pain on the left is fairly short-lived, usually a day or two. The pain on the right can be quite more severe. Pain can last, sometimes up to 3 weeks after excising a hemorrhoid. And every time people go to the bathroom, it hurts. It's a big investment to go through that surgery to relieve hemorrhoid issues. So we definitely kind of reserve that for people with recurrent symptoms who are really suffering from their hemorrhoids. Because otherwise, if you've only had one episode, the investment of pain and recovery may not, it may not be worth it. But for those with repeated episodes, it definitely is. It's an unfortunate reality that people will have pain in the anal canal after surgery. There's just an incredible amount of nerve fibers there. It's an amazing part of the human body that one of my mentors used to tell me, you can pass gas and not let out stool and do it upside down. You couldn't do that with your hands or your mouth if you tried. So it's an amazing feat. It just takes a lot of nerve fibers to make that happen. But unfortunately for us, that leads to a lot of pain post-operatively. Internal hemorrhoids are quite different. These have symptoms of prolapse and bleeding, meaning when patients have issues with internal hemorrhoids, hemorrhoids that are above the dentate line, they may pass a bowel movement and feel something sort of pop out of their anus, almost like the size of a grape, sometimes larger. And sometimes it'll go back in all by itself. Sometimes have to push it back in. They'll also experience rectal bleeding. Patients can experience really bright red blood with bowel movements if they've been having enlargement of their internal hemorrhoids. And it can be an alarming amount. Sometimes people say they looked in the toilet bowl and it was just completely full of blood. And they went into almost a panic. And I've had patients report, being out and walking and getting home and just noticing, a lot of bright red blood in their underwear or even on their pants. It can be a very alarming problem. It typically has no pain associated with it, but occasionally we'll have itching. If people have prolapse symptoms where the hemorrhoid is popping in and out of the anal canal, sometimes they'll get some perianal itching from that. This affects people of all ages. I've had teenagers with prolapsing internal hemorrhoids or bleeding internal hemorrhoids, all the way up into the end of people's life. We have a grading scale for internal hemorrhoids, grade 1 through 4, and these are really related to the degree of prolapse. So grade 1 internal hemorrhoids are the type that only bleed. The patient never experiences them coming in and out of the anal canal. Grade 2 internal hemorrhoids are where they'll pop out of the anus but go back inside all by themselves. They'll just sort of feel a sensation of something popping out. But then when they stand up after defecating, it reduces itself and they may feel nothing there at all. Grade 3 internal hemorrhoids are where the hemorrhoid is popped out and it won't go back in on its own. It's big enough that when the sphincter squeezes shut, it gets stuck outside. And these are what we say require manual reduction, where people actually need to push it back in. A lot of times we'll hear that report of, them doing it in the shower or something like that, that they'll feel it pop out and they'll have to help guide it back in. And grade 4 internal hemorrhoids are a bit bigger, and those get stuck outside and people can't get them back in. Rarely, very rarely, there can lead to an emergent situation where the hemorrhoids can lose their blood supply and get infected. But for the most part, these are issues that sort of just come in through a clinic evaluation. Oftentimes, people will get a report on their colonoscopy if they have internal hemorrhoids, and I think it's really important to note that if you're not having any symptoms from your internal hemorrhoids, like someone told you have them, but you have no symptoms from it, those don't require any treatment at all. As I said before, we all have hemorrhoids. We're born with them. And just like everything else in the world, there's varying degrees of normal on how big something can be. But if you're not having any symptoms from it, we can't make it better than symptom free. So those will typically completely leave alone. Unlike external hemorrhoids, because these are above that dentate line and lack real sensory pain fibers, a lot of these we can treat just right in the office with pretty minimal pain or discomfort. We do, again, similar to external hemorrhoids, shoot for symptomatic relief with fiber and water supplementation. It's really hard in the US to get enough fiber in your diet. So taking a supplement like Metamucil or Citracel, or they now have these things called fiber gummies or chewables, and they taste great and they're really easy to take, can help promote people having soft bowel movements that they don't have to strain to defecate. And again, just like external hemorrhoids, decreasing toileting time can go a long way to reducing the swelling of the hemorrhoid veins. For those that don't respond to those measures, we have a lot of other options for internal hemorrhoids, including something called rubber band ligation, infrared photocoagulation, sclerotherapy, and transanal hemorrhoidal dearterialization. And we'll go through all those. It gets to be a little bit of a word jumble there on which treatment you're going to have and what they all mean. It's really can get confusing on all these options that are out there. And a lot of it's regional too. Depending where you train and what you do the most of can oftentimes guide how you treat people moving forward. The most common way to treat internal hemorrhoids is this technique called rubber band ligation. And what we do for this is in the office, no anesthesia, often in the same visit that the hemorrhoids are diagnosed. We use this device to guide the hemorrhoids through a small metal cylinder. And you can see these little black rubber bands depicted here on the cylinder. They get pushed over the top of the hemorrhoid and ligated at its base. These bands are really small. You know, they stretch really well, but they also squeeze very tight. They're about the size of the rubber bands you would see on someone's braces. And they squeeze really tight around the base of the hemorrhoid and completely cut off the blood supply to that hemorrhoid. And once it loses its blood supply, the hemorrhoid will just slough off and get passed with a bowel movement. That typically just takes a few days. And usually after a few, after like 4 to 6 weeks, we'll have the person come back and ensure that it was effective. They've had resolution of their pain, prolapse symptoms or resolution of any bleeding. And if it wasn't effective, sometimes it requires a second round of treatment. But this is very well tolerated. People don't need typically any time off work. They're not having severe pain with bowel movements like with the excisional hemorrhoidectomy that we discussed earlier. You can eat anything the same day and really do any activity the same day as well. This is, a very common procedure. I probably a quarter of the patients we'll see on any given clinic. If we say 20 to 30 patients in a day, probably a quarter of them will be, have internal hemorrhoids that we'll talk about doing a rubber band ligation for. Two other options used a little less frequently. One is the infrared coagulation. I typically don't use this one almost at all. It's not as effective as the rubber bands. And has about the same symptom profile afterwards. So I've never found a huge benefit, but in case you find it in your reading, it is a a technique that's kind of used depending who you'll see. It's not definitely not a bad technique. I wouldn't say that, just not one I use all that frequently. And then sclerotherapy is another technique. This is where we'll inject the hemorrhoid complex with a sclerosing agent, a medicine that sort of makes those veins just thrombose and crinkle up and shrivel up. There's a few different medications you can use to achieve that. And this is a technique I will use, but typically just on patients who are on blood thinners and cannot come off them. There's rare complications from the rubber band ligations of bleeding, where I'm going to go back one slide. You can imagine if these bands, if the hemorrhoid falls off, if someone's on a blood thinner, they may not have put down enough scar tissue underneath that band that when it falls off, they can have a significant bleed just from the wall of the rectum. Just like if you were to cut yourself shaving or cut yourself just on a sharp object while on a blood thinner, it may bleed quite a bit more than normal. The same thing can happen with these internal hemorrhoids. So if patients cannot come off their blood thinners, that's when I'm just going to turn my, give me one sec, my office light turned off for anyone who's following the video. Sitting too still here. the sclerosing agent can be a great option. Again, not quite as effective as rubber bands in resolution, can require additional treatments, but it's a safe way to proceed if people are on a blood thinner they can't discontinue. This is another technique that I'll use, not infrequently. It's very similar to rubber band ligation, but again, in reading, you may come across this. It's called a transanal hemorrhoidal dearterialization. And it's a really long name to describe putting a stitch around the hemorrhoid column. What we do in this technique is identify the blood vessel that's feeding the hemorrhoid column and supplying its blood supply. And you take a suture, just like a stitch or suture we'll use for any other type of surgery, and you go around that vessel and you tie it, and that cuts off the blood supply to the hemorrhoid. Um, this is a great option for someone who's not a good candidate for rubber band ligation. Maybe their hemorrhoids are too big, they won't even fit in the bander. This is a great way to proceed with those. Also very well tolerated. The one big drawback to this technique is that we do have to do it in the operating room. So that's extra time out of someone's schedule or taking time off work. People need to have some anesthesia for this, which can be a drawback. But it's a really great technique that we don't use infrequently, but not as commonly as the rubber bands for sure. Again, but not as painful, anywhere near as painful or uncomfortable as an excisional hemorrhoidectomy. And I think that I should have said that back when I described excisional hemorrhoidectomies. If you've ever heard a bad story of someone having their hemorrhoids operated on, that can really keep people coming in from being seen or getting treated. They're usually talking about an excisional hemorrhoidectomy, but all these other treatments are nothing like that at all. And we see patients all the time that have been dealing with issues with prolapse and bleeding for 20, 30 years and avoiding coming in because they had a friend once who had a bad experience. And it's amazing to have go that long with all those problems with prolapse and bleeding. We do their rubber bands and, a few weeks later, they never experience it again. And they're amazed. So it's definitely something that's a very treatable problem that we see very frequently. I wanted to discuss real quick as well anal fissures, because this is probably one of the most common diagnoses I see when someone comes in for an evaluation of hemorrhoids. Is actually a totally different diagnosis called anal fissure. And it's because the symptoms very much overlap hemorrhoids, and hemorrhoids are so much better known than anal fissures. Typically, when people experience a fissure, which is just a cut in the anal canal, you can see here, kind of on the photo, on the bottom of the anal canal here, in the posterior anal canal, there's what looks like a little tear, almost a little ellipse, and you can see a little exposed sphincter fibers. People can get a fissure from a very firm bowel movement, where just the skin of the anal canal is very delicate; it'll split. And that tear can become chronic where it won't heal. And people will experience a very sharp pain when they go to the bathroom, followed by bright red blood that they see on the toilet paper. And oftentimes they'll get this deep aching pain as well that is from the sphincter muscle being in spasm. It just is involuntary, and it's a result of the fissure being there. Their anal sphincter will just kind of just spasm and create this deep throbbing pain. Those symptoms very much overlap with a lot of hemorrhoid problems. And if you're not kind of conditioned to seeing these all the time, it can very easy to confuse the two. They're treated completely different than hemorrhoids. Usually we'll start the same way with fiber and water supplementation. I should buy stock in Metamucil. Honestly, I recommend it so much. I'm not, but it's really helps a lot with all these anal problems, fissures especially, because any firm bowel movement will split that fissure open again. If that doesn't work, that's when we'll use some special creams. They're not a cream you can just buy over the counter. They're a prescription medication, and they're actually blood pressure medications that we'll put into cream form. Nitroglycerin is one of them, diltiazem is another, and nifedipine is a third. Again, depending where you train and what you're kind of most comfortable using is kind of what guides prescribing patterns, but they all work, almost the same. one drawback to nitroglycerin is that can cause headaches. So that leads to people not using it. So most of the time people will use either nifedipine or diltiazem. Those are very effective at healing fissures. 70% of fissures will heal with those topical agents, fiber and water supplementation. For the ones that don't heal with those, that's when we'll have some other procedures we can recommend or proceed with. Botox is one. People are always a little surprised when we'll bring up Botox, not really for cosmesis, but this is to relax the anal sphincter. When the sphincter goes into that state of spasm, it can almost cut off its own blood supply. Similar to if you were to squeeze your finger really tight and it starts to turn white, the same thing will happen where this anal fissure is. You need a really good blood supply to heal wounds, so that sphincter spasm can lead to that wound not healing correctly. Botox can help paralyze that muscle. That's how it works temporarily, and allow the fissure to heal. And then by the time the Botox wears off, the fissure should have completely healed and people are kind of back to normal. And for those patients that fail Botox or patients that aren't interested in Botox, the success profile is a little low compared to the next option, internal sphincterotomy. That's when we'll go to actually dividing or cutting some of the internal sphincter muscle. There's very low rates, but not zero, of some fecal incontinence symptoms like leaking some stool or accidentally passing gas. Again, those are incredibly rare. I'm not sure I've ever had a patient report that, but it's reported in the literature. So it's something always on our mind and why we go through a kind of a staged approach for treating anal fissures. But these, again, very common problems that are rarely talked about, that if you haven't experienced it yourself, you definitely know someone who has, but very often confused with hemorrhoids, but treated in a very different way. So key takeaways when you're thinking about hemorrhoids, if you've ever experienced it or someone's kind of running their symptoms by you, or things to kind of think about if you're going into your primary care visit. External hemorrhoids will have more of a throbbing pain. Oftentimes you'll feel a lump outside the anus, typically associated with straining, and usually will only bleed if it ruptures, but that always is after the pain has occurred, and usually it'll be a dark blood as opposed to bright red. Internal hemorrhoids typically have no pain associated with them. Symptoms are usually prolapse, coming out of the anus with defecation or walking, and bleeding. And the bleeding is generally always very bright red, because it's right there at the anus. It has no time to mix with any of the intestinal digestive enzymes. And then an anal fissure is sharp pain. So different than external hemorrhoid, it's a sharp pain, almost like a knife-like pain, that is worse with defecation. And then a spasm or aching type pain that follows bowel movements. But it's typically that pattern, a sharp pain with defecation, and then an aching or spasm type pain after bowel movements. This will also, similar to internal hemorrhoids, have bright red blood, but typically only enough to spot the toilet paper, not bright red blood that will drip into the toilet bowl or completely fill the toilet bowl. And similar to the other diagnoses, is very often associated with constipation, frequent or chronic diarrhea, or potentially a traumatic situation. Other key takeaways are that these are just very common problems. They affect so many patients. They affect patients across all demographics. This is definitely a great unifier of people throughout the world. Asymptomatic hemorrhoids don't need any treatment at all. We all have them. We're born with hemorrhoids, and there's a range of normal, and they can tend to enlarge throughout age. But again, if they're not causing symptoms that are bothersome to your life, there's no need to do any procedures for them. There's many causes for hemorrhoids becoming enlarged or symptomatic. I think it's important to know if you're experiencing any anal pain or any rectal bleeding, you should be evaluated. Colon and rectal cancers and anal cancers often will present with bleeding as well. Rectal tumors or anal tumors that are very low in the anal canal can present with pain. So I think until it's been completely worked up and you have a diagnosis, it's the best idea is to get checked out. because if you catch a colon or rectal cancer early or an anal cancer early, they're very, very, very treatable. And I take care of a lot of colon and rectal surgery patients, and it's not infrequent that someone had bleeding for months or even over a year, and it was chalked up to hemorrhoids or chalked up to an anal fissure, and just a really thorough exam may have detected something quite a bit earlier. So while these are common problems, it's definitely best to get checked out because it's a very hard area to examine yourself. Um, and things like us looking in the office with anoscopy or a colonoscopy or just a physical exam are all very, very safe ways to make that determination.